Sir, we are live now. With all your permission, I'm starting this session.
Yes.
Good evening, everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, Dr. Lieutenant General Ved Chaturvedi, sir. Sir has done MBBS, MD, DM, and Senior Consultant at Sir Gangaram Hospital and Vice President of Asia Pacific Rheumatology League, APLAR. Today, sir is going to discuss on a topic autoimmune arthritis and overview on the occasion of World Autoimmune Arthritis Day. Let me tell you overview of the topic. Autoimmune arthritis is a group of rheumatic disease that occurs when the immune system mistakenly attacks healthy joint tissues, causing inflammation, pain, and stiffness. This type of arthritis can affect people of any age and gender, but it is more common in women. This condition can cause joint damage, deformities, and disabilities if left untreated. To know more about this topic on the occasion of World Immunoarthritis Day, I would like to invite sir and hand over this session to sir. Over to you. Kindly proceed from here.
Thank you so much. Thanks. First, my association with the late Padam Shri Dr. K.K. Agrawal. We were very closely associated. Not many people know that I was in Army Hospital that time. This is my photo in when I was in Army Hospital. That time, I had called him first to my hospital, and then we developed friendship, and I was really admiring him. I could see so many things which he did beside a good doctor, and I was amazed. Now I'm retired from Army, and now I'm working in Gangaram Hospital. I'm currently vice president of an organization called Asia Pacific League of Rheumatology. And we were the first few rheumatologists who were DM qualified from 1990 from SGPGI Lucknow. And then I was heading, as I said, the Army Hospital, Delhi. And we started the biologics first time in the country. And we started the ultrasound in the rheumatology first time in the country from 2004. And currently I'm vice president of Asia Pacific League of Rheumatology, which is popular called APLAR. So this is the just a minute. I think it's not moving. Let me see. Yeah. This was my old hospital, Army Hospital, where I was working in uniform. And currently I'm working in this hospital, Gangaram Hospital, equally good hospital. So I'm working for last 6-7 years. Now, first thing I must tell you, whosoever is listener may be a very, I don't know who all are listening this lecture, but I must tell you, if somebody makes a lecture very difficult, probably he himself has not understood. So my idea is to make things simple. I'll tell you, these two gentlemen, I don't know whether the new generation know them. First was Naushad, who gave music to Mughal Azam. And another gentleman was O.P. Nayyar. This is O.P. Nayyar. O.P. Nayyar. So O.P. Nayyar used to make simple tunes while Naushad. So the Naushad cook was cooking and singing the O.P. Nayyar's tune. To that, Naushad was very unhappy. He said, why you don't sing my song? He says, you make such a difficult tune. So that's why Naushad understood that he has to make the tune very simple. So I'll keep my lecture very simple so people understand whether you are MBBS or you are non-MBBS or you are MD or DM. I did my DM 1991, long back. 1991 super specialties were cardiology. Most of the people used to go to cardiology, gastro, neuro, endocrine. So when I joined rheumatology, literally people were gunning at me that why you want to join rheumatology. So I must tell you today, what has emerged in last 25, 26 years back, that rheumatology has emerged as a last bastion for clinician. So if you are a clinician, you may be MBBS, you may be a medical student, you may be intern, you may be physician. It is the last bastion for clinician. The diagnosis is clinical. So it's a clinical specialty. Whatever those tests are there, I'll try to make you understand they are very simple tests. 90% diagnosis is done by history. If you understand that, then that is and rheumatology is also called as rheumatology and clinical immunology, because immunological diseases, mostly actually the maximum work was done in joint diseases. It's not that the liver disease is not autoimmune. Liver disease can also be autoimmune, but maximum work has been done in rheumatology. Now, my brief is to talk about autoimmune diseases. That I'll come later, and I'll tell you the uh, look. So there are big four of rheumatology. Now, what we do in how we see the rheumatology. If you ask me, a lot of joint diseases people, a lot of people ask me, a lot of doctors ask me that what comes in rheumatology. So I'll tell you what comes in rheumatology. These are the few things come in rheumatology. Out of that, the autoimmune diseases are these, only 9. Most of the diseases are not non-autoimmune. So you have a osteoarthritis, which is non-autoimmune. This is, you have sometimes low backache, sometimes soft tissue rheumatism. So this 9% people, they are more, the disease are red flag, or it's something like benign in cancer, the cancerous. So it is more of a cancerous things. So if you really ask me, if I'm sitting in OPD, I see 100 patients, 9 patients I see the autoimmune diseases, rest I see non-autoimmune. But the patient face, he will not come that I have autoimmune disease. So you have to really understand about non-autoimmune disease also. If you want to practice autoimmune diseases or rheumatology, you have to understand all this, and then you should know the difference between non-autoimmune and autoimmune disease, inflammatory and non-inflammatory. And these are called as inflammatory rheumatic diseases. So they are more dangerous than these diseases. So that is what I'm going to discuss. So just like neurology. Now, neurology has been taught to me. I'm from 1971 batch. I'm not a youngster. I joined in 1971 medical college. That time also, we knew the level of lesion, upper motor neuron, lower motor neuron lesion. Same as has happened in rheumatology. What is the level of lesion? If there is swelling in the joint, is it the level of lesion is cartilage? If the level of lesion is cartilage, it is a osteoarthritis, which is non-autoimmune. If the level of lesion is synovium is this, which lines the joint, then the disease is rheumatoid arthritis, which is a autoimmune disease. If the level of lesion is tendons, ligaments, and tendon insertion, which we call as enthesis, then the level of lesion, then the disease is spondyloarthropathy or ankylosing spondylitis. And if the level of lesion is synovial fluid, then that it is gout. So on and so forth. If you remember this photograph, I think my half of the job is done. But in 1991 also, I realized there's something more has to be done beside antibodies. We had antibodies. So we always thought antibodies are quite thrilling. You can say rheumatoid factor is antibody. You can say anti-nuclear antibody is a nuclear antibody. Anti-CCP is antibody. But I thought we must develop, and what I did, I developed ultrasound in rheumatology in 2003. When I passed out my DM, I came to Army Hospital. Around same time, the Europeans were also developing the ultrasound. It was 2003, almost 20 years back. And I had a high frequency probe, and that we acquired through IIT. And we were doing, and people were surprised in Europe also that in Army Hospital, we are doing ultrasound of the joint. So that was the first we developed, for the first time in this country, we developed ultrasound of the joint. My own colleagues used to laugh at me, and that causes more research into the rheumatology, like peeping inside the joint. And we also started doing arthroscopy, because people thought arthroscopy means orthopedic surgeon. You peep in the joint. So they do a bigger job through arthroscope. Arthroscope is same. a surgeon do surgery through arthroscope. What I used to do is annual documentation and taking a biopsy from the correct place. And this we organize a workshop also in 2003. So we had organized a workshop of the arthroscopy for the people during our Indian Rheumatology Association. So I always call autoimmune arthritis or arthritis as a painful paralysis. Paralysis we all know very well, but this is a painful paralysis. If you develop arthritis, then you gradually become the wheel bound or a home bound. A lot of people you must have seen, your old people, your old parents and grandparents who were very fit. Suddenly you will find them in the house. They don't go to the parties, they don't go to the marriages. So it is a painful paralysis. Now, if some arthritis patient comes to me, or if they come to you, I must tell you a very small things. As I promised you that I'll make a lecture very simple, that you don't jump that this person has an autoimmune arthritis. You, as a physician, as a doctor, you may be MBBS doctor, you may be MD, you must have an approach of a doctor that if some patient says, I have a joint pain, and suddenly you write rheumatoid factor, no. You first think, is he having an infection like viral? Like yesterday, I had a severe joint pain because of infections, and that is a viral arthritis. So there are many infections. Not one, tuberculosis can cause, the gonococcal can cause, and so many things. So infection also can cause arthralgias or arthritis. So that is number one. The second is diabetes and thyroid. Every patient, he comes to me, I always ask, do you have diabetes? Do you have thyroid? First question, diabetic can also leads to arthritis, which is looks like a rheumatoid arthritis. We call as diabetic chiroarthropathy. Thyroid diseases has hypothyroidism can cause. Sometimes patient who has a severe anemia, he comes with joint pain, and you correct the anemia, joint pain goes away. So is he anemic? Depression is a very important cause, though it is listed last. But I can tell you, you ask a person who is in psychiatry and psychiatric patients, and they have severe joint pains, not exactly arthritis, but joint pain. And of course, sometimes the lymphoma, leukemia, and multiple myeloma, they can cause a lot of joint problem and frank arthritis. So beside a autoimmune arthritis, a physician's approach should be, is it something else? Is it diabetes? Is it thyroid? Is it anemia? Is it infection? Is it depression? Sometime when you exclude all this, you ask patient, is he taking a drug? Some drugs, I'll give you example. A very important person in this city is still a very senior IAS officer. His wife came to me, and she was very pretty looking, and I had met her long back, about 2-3 years back. Suddenly her husband came, and she was in wheelchair. She was not in wheelchair. She was on a she was in a trolley and not well kept. I said, what happened? He said, look, I have shown to all the doctors, and she is not becoming all right. And she has aches and pains, severe aches and pains. And everybody has seen. So I said, what happened? I heard the whole story. She had a breast abscess, which was diagnosed as tuberculosis. So she was on anti-tubercular drug. And because of anti-tubercular drug, she developed severe arthritis. It can happen, which we call it drug-induced lupus. So drugs can also cause, there are many other drugs which can cause joint pain. So that is one issue. Sometimes hypermobility syndrome, which is so common in society that your joint moves more than what is required. They are called hypermobility syndrome. There was research was done. What is a hypermobility syndrome? The one thing you must remember as a physician, that normally we can touch the tips of our fingers to the floor. So if you bend, you can, with the practice, you can always touch the tips of your fingers, but you can't touch the palm. if you can touch the palm, then this is one of the features of hypermobility syndrome. They are the people who has a lot of aches and pain, and of course, sometimes a primary bone disease and some neurological disease like Parkinsonism. They look like somebody has a arthritis. So you must exclude all those diseases if you're a good doctor, whether this person has a autoimmune arthritis or now this is a patient I still remember. He was country's defense secretary, and he had gone to a very big hospital where he was diagnosed as rheumatoid arthritis. And when he came to me, the only question I asked him, "Are you suffering from diabetes?" He says, "Yes, doctor, I'm suffering from diabetes, but they have not asked me." I said, "This is diabetic chiroarthropathy. This is not rheumatoid arthritis." So it looks like rheumatoid arthritis because your movements become very stiff. And this is called limited joint motion, LJM syndrome. And because of the tenosynovitis, it's not a rheumatoid arthritis. So you must ask the history of diabetes. You must ask the history of the hypothyroidism. You must remember it could be paraneoplastic syndrome like ALL, AML. I can give you examples and after example. I still remember when I was in Army hospital in the evening, I got a call that somebody is admitted with backache. I said, "Oh, admit him. We'll see him tomorrow." "No, Doctor, he's having severe backache." Somebody's servant. I said, "Severe backache, young person." I said, "Okay, admit him." So we thought maybe PIVD or something. A simple test was done in the evening. It was turned out to be AML. So acute myeloid leukemia, acute lymphatic leukemia. These children also, ALL is common in children. They present with arthritis also. So they sometimes presenting feature can be arthritis. I'll give you example. This IAS officer used to come to me and he was in a home ministry, a very important person. And he was a little hefty. He used to have a lot of aches and pains. And I saw everything was normal. I just could not diagnose. And I said, "You can go to some other doctor." He says, "I have shown to everybody." Everybody says, it is in your mind." One day he came in shorts, and in the shorts, I could make out the way he was standing. He was standing like a child with hyperextension of the knee joint. Children generally stand with hyperextension of the knee joint. He had all the other features of hypermobility. As I said, hypermobility can cause a lot of aches and pains, which looks like arthritis or arthralgia. So these are the features, as I was mentioning, that I made him to do it like this. He was a hefty person, but he could do this. And he could, his fingers were hypermobile. So a lot of features, these are tests for hypermobility. You can see that. So you must remember hypermobility as an important cause of arthralgia or joint pain. I still miss it. Though I keep remembering it, I still miss it. So you should not miss it. You must remember, is it hypermobility? If everything is normal, just see that is it hypermobility syndrome. This was another patient who was sent to me and from an eye specialist that he has backache and neurophysician had seen. And they said, "Look, these SI joint are very prominent. Probably it is ankylosing spondylitis." I could see that you can't see the bone also. The bone calcium has gone. I said, "This is severe osteoporosis, generalized osteoporosis." At 75 years, it's written wrong. But 75-year-old, I still remember he was chair-borne. And in the OPD only, I saw he was highly anemic. I put a needle and as a bone marrow I did and diagnosed as myeloma. So that multiple myeloma is another which can present as a backache or arthritis. Another patient, middle-aged female, pain, aches and pains like this. In fact, if you really ask me, joints are normal, but they will have tingling, numbness, aggravated during night. They'll say a lot of pain. This is carpal tunnel syndrome, which is very common. Taught to us, we forget tingling, numbness. That is not the arthritis. So another patient who had a monoarthritis and came to me as a child, I always thought he was sent by pediatrician. I thought it is tuberculosis. No, that he thought it is tuberculosis. I say it's not tuberculosis. It is a autoimmune disease, juvenile arthritis. And I wrote the treatment, but I got a ring from that doctor from Sagar. He told me, no, he's not doing well. He's having a lot of aches and pains. I said, okay, send to me. He came. I thought I'll do a biopsy because that time we were doing a lot of arthroscopy. So before arthroscopy, luckily, I review his X-ray. And believe me, I thought there is something wrong in the X-ray. And I sent it to my orthopedic surgeon. Look, I feel there is something wrong in this X-ray, which I can't make out what it is. You know, what was the diagnosis? Was osteogenic sarcoma. So sometime they will present as a arthritis, and it was an osteogenic sarcoma. So I must emphasize before labeling somebody that he has arthritis, you must have a comprehensive. That's why this rheumatology, as I say, it's a specialty of the clinician. It's a clinical bastion. It's a clinical fort. You must examine patient from head to toe. It's not like, so you must see whether he has a skin lesions for lupus. He must have eye like scleritis, episcleritis for vasculitis. You have a GI involvement, which happens in many diseases, and renal involvement happen, lupus, and other. Every system can be affected by autoimmune disease. Now, what is an autoimmune disease? If it affects if your immune system attack your joint, you develop arthritis. And if arthritis is there, then of course rheumatologists they come. But sometimes all over patient come to us. Sometimes skin specialists send to us, look, it looks like autoimmune disease, they send to us. Eyes doctors now have become very aware, so they send patient to us. Look, he has a episcleritis, he has a scleritis, probably a vasculitis, you say. Sometimes people, the nephrologist colleagues, they send to us, look, he has a renal failure. The cause is autoimmune. So autoimmune diseases are different. Autoimmune arthritis is different. Today, I'm more and more discussing about autoimmune diseases, particularly autoimmune arthritis. So the first word, as a good doctor, you must use the correct word as we use in the language. So the first correct word is arthralgia versus arthritis. So the first thing you ask whether somebody has a swelling. Now, swelling is more important than no swelling, but he has a joint pain. So joint pain is called as arthralgia, and when there's a swelling, it is called as arthritis. The swelling denotes immune inflammation or inflammation. So you must know if there is inflammation, that is more important than rather than no inflammation. But more and more things are changing with the ultrasound, because once we do ultrasound of these patients, you can see even fluid there. So they are also having, so but from a practical point of view, you must remember the difference between arthralgia and arthritis. That arthritis means swelling, arthralgia means no swelling, but pain is there. The first thing you must find out, is it really the joint pain? Or joint pains are not there. Actually, it is arising from structures away from the joints. And I'll give you an example how it is. What I do, I just take a red and blue pen. If there's a swelling, I mark it red. If there is only pain, I mark it blue. And that makes my job very simple, arthralgia and arthritis. And I call it red and blue method, or my own method, Ved method, whatever you call it. It's not, I have not validated it, but that is not the question. It's making life more simple, easy in the OPD. So what is arthralgia? I'll give you example. Periarticular tissue. Periarticular tissue is tennis elbow, because tennis elbow everybody knows. So of course this is not the tennis elbow. Tennis elbow is basically the which we all keep seeing tennis elbow. That is periarticular structure, because that is the not in the joint, outside the joint. So that is a pericardial, like this. Enthesitis, this is it. So these are the ligaments are involved, this is also ligament which is involved. So they are not joint pain, but people will come with pain. Doctor साहब, मुझे कोई joint disease हो गया, मुझे pain हो रहा. So you must know, is it a joint or a periarticular structure? So the first question you have to see, is it articular or periarticular? So we start from here. So articular or periarticular? Is a joint or a paraarticular structure is involved? Periarticular problem can be everywhere. Elbow, you know, tennis elbow very well. I showed you ankle. So this is also not a joint. This is a ligament problem. And of course, a lot of shoulder issues like which is very common, which you call it the frozen shoulder, and a lot of other things. I described you diabetic arthropathy, carpal tunnel syndrome, decoherent synovitis, and so on and so forth. And you must realize that the pains, there are many types of pain. Deep-seated pains are from bone, and fibromyalgia have a tender joint, so they are different type. I make it more further simpler. If some old person walks, what is the diagnosis? If a child walks to me with arthritis, what is the diagnosis? Where a young female walks, so let's start. A person, an old person, I'm sitting in the OPD, and somebody gives a call, please see my father, and he has arthritis. His both the knee are paining. He can't walk. Even if I have not seen patient, it is our ex-Prime Minister, late Atal Bihari Vajpayee ji, which I happened to see him at Army Hospital, and the diagnosis was osteoarthritis. So osteoarthritis. If some person comes with the arthritis of both the knee joint, so they will generally, if you see your old parents, they will have bowing like this because that deformity they develop. And if some young person, young male walks to me and he says, I have a backache in this region I call as undergarment region, where you can have backache, you have a side pain. So I always sometimes call it buttock pain or a back pocket pain or a side pocket pain. And this pain is inflammatory in nature. Inflammatory means it becomes worse in the night, and when he walks around, he becomes better. So inflammatory backache, a male person, a young person walks to me, I diagnose as spondyloarthropathy, or a popular term, ankylosing spondylitis. So this is how the young person presents. If you diagnose him at this stage, if you don't diagnose him at this stage, gradually he becomes like this, and there is no point diagnosing him at this stage. This is bamboo spine with so this is how it is pick up. If a young female walks to me, 25 to 35, and his hand joints are involved, he says, I have an arthritis of small joints of hand. Other joints are also involved, but hand joints give you comfort that it is rheumatoid arthritis. Again, inflammatory in nature. So if somebody says, Doctor Saab, I have become worse in the morning. When I get up in the morning or in the night, then my joints pains, aches more. But when I move around, I become better. This is called as inflammatory arthritis. Most likely rheumatoid arthritis. And if you don't treat them, they become like this. So this is how it goes. So how you differentiate between these two? Mostly rheumatoid arthritis, mostly they are female patients, while ankylosing spondylitis or spondyloarthropathy, they are the male patients. What is the level of lesion? Is generally the hand joints are involved in rheumatoid arthritis, while spinal joints, as I said, the back and the spine is involved in ankylosing spondylitis. And it's a synovial disease, rheumatoid arthritis, while this is a ligament disease. Rheumatoid factor is generally positive in rheumatoid arthritis, while HLA-B27 is generally positive in both are young, more females, more males. So that's very important. Of course, children, if they get arthritis, a diagnosis is juvenile arthritis. So at least you must know to write a simple word, juvenile arthritis. There are many types of juvenile arthritis, but just simply write juvenile arthritis. So you have seen the periarticular and articular. If articular is there, then non-inflammatory is osteoarthritis. Inflammatory, I told you, like osteoarthritis is non-inflammatory, and inflammatory is rheumatoid arthritis and ankylosing spondylitis. So how we differentiate? Because they look similar. Otherwise, you will keep diagnosing this is osteoarthritis of hand. It looks like rheumatoid arthritis. Both, when I was young rheumatologist, I used to get confused. But in the osteoarthritis and rheumatoid arthritis, it is an inflammatory arthritis. If you don't treat, that will take away the joints very soon. It's a systemic disease. It can kill also. This will trouble you. So your first thing you must diagnose, is it an inflammatory arthritis or a non-inflammatory arthritis? It is a autoimmune arthritis. It is a non-autoimmune arthritis, because disease, it's a red flag arthritis. It's a non-red flag arthritis. It is something like a cancer. This is a benign. So how we differentiate, it's a very crucial, because entirely management is different. So inflammatory arthritis is worst after rest. So if you take a rest, whole night you have taken rest, in the morning you get up, your symptoms are worst. It improves with exercise. The disease fluctuates its course. डॉक्टर साहब अभी तो ठीक था, 2 महीने फिर ठीक हो गया. फ्लक्चुएशन कोर्स. कॉन्स्टिट्यूशनल सिम्टम, डॉक्टर साहब मुझे थोड़ा सा बुखार भी रहता है, तो बहुत ही थक जाता हूँ. कॉन्स्टिट्यूशनल सिम्टम and high ESR, high CRP, and other acute phase reactants can be high. Hemoglobin is low, because all these features, they attack your factory of hemoglobin. So it is called anemia of chronic disease. So this is all inflammatory arthritis or a red flag arthritis. Just reverse is non-inflammatory, that they are okay, but when they walk around, they become worse. So like an old person, like our ex-prime minister, if he's sitting on chair, is fine, but the moment he walks, he gets pain. So he's worse after the exercise or worse after walking. So this is just reverse of this, is non-inflammatory. So this is inflammatory and non-inflammatory. Classical example of inflammatory is rheumatoid arthritis, lupus, and ankylosing spondylitis or SPA. While non-inflammatory is all this osteoarthritis, hypothyroidism. They don't have much morning stiffness. They have significant morning stiffness. The pain aggravates on resting. So morning mein they are worse. The pain aggravates on moving the joint. Spontaneous flares is common. This and acute phase reaction like ESR, CRP goes high in inflammatory. Well, they are normal in this. So what is acute phase reactant? Now, all autoimmune diseases, there's an autoimmune inflammation. When there is an inflammation, body reacts to it. How it reacts? There's a protein which is actually manufactured in liver. The liver start making more protein, and this protein is called C-reactive protein. So see how the CRP goes high. So this is called CRP. What is CRP? Full form is C-reactive protein. From where it comes? It comes from liver. How it rises? It rises because of autoimmune inflammation. Is it specific? No, it's not specific. It can rise in any inflammation. Others also rises, like serum amyloid also rises, haptoglobins also rises, fibrinoglobulins. All can rise. There are many, but just remember CRP. Forget about others at your stage. So you have diagnosed between the inflammatory versus non-inflammatory, means autoimmune versus not autoimmune. So it's very, very important to diagnose it. Once you have diagnosed it inflammatory, then you must remember, is it a multiple joints or single joint or in between? So multiple joints are called as polyarthritis. Otherwise, they call this oligoarthritis and monoarthritis. Just remember the two words, poly and mono. I think that's better. Just remember polyarthritis. Polyarthritis, classical example is rheumatoid arthritis. SLE also, psoriasis also. And monoarthritis is tuberculosis, we remember. Sepsis, we remember. Gout, we remember. And in between is some diseases, forget about it. So pattern recognition is very important. Pattern recognitions is a very, very important. Like you must differentiate, is it a symmetrical, asymmetrical, number of affected joints, is it acute or chronic, and one by one and if everything is it acute or in serious, is it a mono or poly, and extra articular features. The moment you finish the joints, Because patient will come, doctor, my elbow is paining. But if you sit down with him, he says, my knee is also swollen. So you must decide whether it's a polyarthritis or monoarthritis. And then you ask other features like a good physician, whether he's running temperature, he has a skin problem, nodules, and is it intermittent, additive, migratory, all those. Like suppose I'll give you an example, acute. डॉक्टर साहब मैं बिल्कुल ठीक था कल और मेरा सडनली लाल हो गया ये ज्वाइंट ये वाला और साहब अभी 2-3 दिन में ठीक हो गया अब इसके बाद साहब मैं बिल्कुल ठीक था अब वैसे फिर हो गया सो इट इज ए gout acute it can be sometimes the acuteness can be because of sepsis also but sepsis doesn't disappear so you can diagnose it as a sepsis or a gout it can be reactive arthritis also इंसीडियस नेचर डॉक्टर साहब इनिशियली 2-3 महीने से मुझे दर्द हो रहा था अब धीरे धीरे थोड़ा स्वेलिंग होने लगी अब डॉक्टर साहब 1-2 महीने गुजर गए ये क्या चीज है मेरे हाथ में मेरा हाथ सूजा रहता है मे बी रूमेटॉइड आर्थराइटिस मे बी एसएलई मे बी पीएसएस SLE presents like this sometime and ankylosing spondylitis I told you is a backache so sometime acute and self limiting हुआ और ठीक हो गया गाउट हुआ और ठीक हो गया वायरल सब डॉक्टर साहब 2-4 दिन से जॉइंट पेन हो रहा था अब ठीक हो गया वायरल इट कैन बी रिएक्टिव आर्थराइटिस आल्सो इट कैन बी रूमेटिक क्रॉनिक गोइंग ऑन डॉक्टर साहब ये ठीक ही नहीं होता थोड़ा बहुत ऊपर नीचे होता रहता बट चला जा रहा है रूमेटॉइड आर्थराइटिस एंकाइलोजिंग स्पॉन्डिलाइटिस सिस्टमिक कनेक्टिव डिसीजेस नंबर ऑफ अफेक्टेड जॉइंट एक ही जोड़ इन्वॉल्व डॉक्टर साहब मेरा एक ही जोड़ में लाल हो रहा है इट कुड बी गाउट as I said, it can be sepsis, septic arthritis. Doctor, बहुत सारे जोड़ों में involvement है, rheumatoid arthritis. In between, it can be osteo, it can be seronegative. So that is the monoarthritis versus polyarthritis. So you must sit down and find out, is it a monoarthritis? Like this boy had a monoarthritis, which could be tubercular, it could be sepsis, it could be acute gout, and it is a polyarticular disease, which is juvenile arthritis. And this person had a sepsis and we aspirated with frank pus. So sometimes a monoarthritis can have a frank pus also. As I said, we were learning that time. This is a very old photograph of Army Hospital. 20 years back, we were learning ultrasound of the joint. So this is the, then you say whether symmetrical or asymmetrical, whether this hand is involved. If other hand is also involved, it's called symmetrical, which happens in rheumatoid and osteoarthritis, and other diseases called asymmetrical. One knee, one ankle, this is called asymmetrical. So polyarthritis, this shoulder, this elbow, this wrist, this knee, This is polyarthritis, rheumatoid arthritis, symmetrical involvement of joint. And this is asymmetrical involvement. One knee here, one knee here. Now, these are the classical cases. Non-classical cases, this is something like psoriasis. Now, so I have written rheumatoid arthritis versus psoriasis. They can have rheumatoid arthritis is an arthritis of small joints, as I said, hand joints, large joints, multiple joints, symmetrical arthritis, inflammatory arthritis, mostly in female. So you from this lecture, you must know how to diagnose rheumatoid arthritis. Rheumatoid arthritis, first thing I told you, a female. She walks in, young female. डॉक्टर साहब मुझको 1-2-3 महीने से चल रहा है क्रॉनिक आर्थराइटिस कहाँ चल रहा है सब हाथों के जोड़ों में पैरों में डॉक्टर साहब पैरों में भी है स्मॉल जॉइंट्स एंड लार्ज जॉइंट्स और सब इस हाथ में दूसरे हाथ में हाथ दूसरे में भी है सिमेट्रिकल इधर भी है So this is how it is diagnosed. DIP joints are spared in the rheumatoid arthritis where DIP joints are involved in psoriasis. And psoriasis, it is asymmetrical. So psoriasis is also a large and small joints, but this is asymmetrical arthritis. DIP joint, large joints of the fingers are also involved. This is important. And it happens in both male and female with the equal frequency, while rheumatoid arthritis is more common in females. So pattern recognition is very important, whether all the joints, like this is a DIP joint involvement, So this is how the wrist are involved, MCP, these joints are involved, but DIP joint. So this is a rheumatoid arthritis pattern, and this is osteoarthritis pattern. Upper limb versus lower limb. This is my favorite. Upper limb involvement, somebody is there, most likely rheumatoid arthritis. Lower limb involvement, most likely the SPA. That is the other joints also, like other conditions also. But moment I see a lower limb joint involvement, I always feel SPA, spondyloarthropathy, or you call it ankylosing spondylitis. Sometimes edema nodosum because of tuberculosis, sarcoidosis, lower limb joints are involved. Gout is involved. So that is the upper limb. Small versus large joints. Large joints are involved in osteoarthritis and SPA. Small joints, more rheumatoid arthritis and connective tissue diseases. So this is how it is. Specific joints. This joint, sacroiliac joint, the joints under your undergarments, sacroiliac joint. This is sacroiliac joint involved in ankylosing spondylitis or SPA. Your DIP joint, distal joints involved in osteoarthritis. So you must remember osteoarthritis and psoriasis. There are two conditions where the DIP joints are involved, and the spine is involved in the spondyloarthropathy or ankylosing spondylitis. Rarely rheumatoid arthritis involves cervical spine. Pattern of involvement additive. एक जॉइंट दूसरा जॉइंट तीसरा जॉइंट चौड़ा रूमेटॉइड आर्थराइटिस क्लासिकल इंटरमिटेंट हुआ ठीक हो गया गाउट reactive arthritis palindromic rheumatism migratory we are learning from MBBS days rheumatic arthritis viral अब यहाँ हुआ एक जॉइंट ठीक हो गया फिर दूसरा जॉइंट हो गया migratory arthritis extra articular feature that makes it absolutely a different specialty than orthopedic. You must remember it's a specialty of medicine. So if somebody has a joint problem, that's why the new specialties has come from last 20 years, which is called rheumatology, because all these questions has to be asked very seriously, whether he has fever with the joint pain, is somebody the fever, it could be SLE, it could be vasculitis, it could be systemic onset GIA, it could be infective endocarditis. If his skin is involved or mucosa is involved, हम एक ही चीज पूछते हैं भाई जोड़ों का इन्वॉल्वमेंट है तुम्हें स्किन में कोई प्रॉब्लम तो नहीं है कोई तुम्हारे मुंह में छाले तो नहीं होते मुंह में छाले होते हैं स्किन है तो एसएलई हो सकती है सोरियासिस हो सकती है बैशेट्स हो सकता है वैस्कुलाइटिस हो सकती है नेल चेंजेस देखेंगे भाई नेल्स ठीक है तुम्हारे हाँ डॉक्टर साहब मेरे नेल्स तो बड़े दिनों से खराब है इट कुड बी सोरियासिस psoriatic arthritis. So this is other extraarticular features. Eye involvement. डॉक्टर साहब मेरी आंख बार बार लाल हो आप आंख के बारे में क्यों पूछ रहे हैं डॉक्टर साहब मेरे को मैं तो अपने कमर के दर्द के लिए आया था आई इन्वॉल्वमेंट सेम कोलाजन इज हियर सेम कोलाजन इन द बैक बोथ आर इन्फ्लेम्ड सो द मोमेंट यू आस्क आपकी आंख लाल होती है हाँ साहब 2-3 बार आंख लाल हो चुकी यूवेआइटिस इन केस ऑफ एंकाइलोसिंग स्पॉन्डिलाइटिस और एसपीए eye can be involved in vasculitis eye can be involved in Sjogren syndrome dryness of so eye you ask about nodules. Nodules can be seen in many conditions. Rheumatoid arthritis is basically you must, after my lecture, you must be able to diagnose. We used to diagnose at this stage. Now we want to diagnose early. You must diagnose, ask whether he has a polyarthritis, a young female, which is inflammatory in nature. Doctor साहब सुबह सुबह मेरे को बहुत तंगी होती है सुबह सुबह मेरे जॉइंट बहुत दर्द करते हैं सुबह सुबह क्यों करते हैं कि whole night में she is taking rest and the inflammatory fluid accumulates here and when she move around and the move disappears the fluid disappears so she is worst in the night but if you don't diagnose it properly if you don't start the DMARDs then this condition this cannot be treated this has to be a surgical management same is this साहब मुझे कमर में दर्द होता है रात में ज्यादा होता है सुबह सुबह ज्यादा होता है inflammatory in nature backache inflammatory in nature more males they can have peripheral joint beside the back even knee joint can be involved ankle joint can be involved so this is the more male disease so the rheumatoid osteoarthritis as I non-inflammatory डॉक्टर साहब मैं बिल्कुल ठीक रहता हूँ सुबह सुबह तो छोटा मोटा होता है बट ठीक रहता हूँ बट मैं चलता हूं तो मुझे दर्द होता है, मैं हाथ में मैं काम करता हूं, मैं सब नाड़ा नहीं बांध पाता. एंड इफ यू केयरफुली सी, ही हैज अ DIP joint involvement. The diagnosis is osteoarthritis, and age is not young, he's an old person, so age is different. Sometime people, you should not forget to ask another question, whether you have got Raynaud's. हाँ डॉक्टर साहब, मेरे हाथ नीले पड़ जाते हैं मेरे. This is systemic, this is a different disease, and you must, this is a, नीले पड़ने का मतलब है blood vessel involvement. It's called vasculopathy, and if it's not treated, the fingers become like this, they lose fingers because the blood supply is affected. So that is how, and skin become thick. This is called systemic sclerosis. Systemic connective tissues, also young females, they are chronic deforming, they also have arthritis, but they have other features like fever, they have skin rash and lupus, and multiple organ involvement. So lupus and other diseases, and like, and eyes, I described to you, mouth, mucosa, I told you, Raynaud's phenomena, I told you, the psoriatic arthritis, I told you, psoriasis means this is a classical psoriasis, and their DIP joints involvement is there. So this is a psoriatic arthritis. This is a gout, which gout, and if you just see if you aspirate it, this swelling, you will have crystals, the crystals in the joint, and this is psoriasis, palmar plantar psoriasis. Investigation, lot of investigation can be done. The most important investigation I feel is hemogram, and other investigation like rheumatoid factor, ANA, dsDNA, and if they are positive, then ENA and HLA-B27, must get an X-ray chest also. So like a physician, you work, if you know the cause, then only you can order investigation. So if I suspect a diabetes, I'll order for diabetes. If I suspect tuberculosis, then I order X-ray chest. If I suspect rheumatoid arthritis, I'll order for rheumatoid factor, anti-CCP. If I suspect SLE, I'll order ANA and dsDNA and ENA. And if I suspect ankylosing spondylitis, I order HLA-B27. Blood sugar in every case, thyroid in every case, viral markers also, an X-ray chest for everybody, and CBC. And of course, if I suspect gout, uric acid. And if there's swelling, synovial fluid is there. And if I suspect gout, I aspirate and see whether there is an infection like septic arthritis or a crystal arthritis. And of course, you can do a CT of the joint, MRI of the sacroiliac joint, and you can see ultrasound, which we started in this country. And ultrasound is like a stethoscope today for a rheumatologist. And we can do synovial biopsy, and like for arthroscope or without arthroscope. And a biopsy is very useful for a blood vessel biopsy or a muscle biopsy for myositis. Now, this is a very classical case which presented as arthritis, where we were learning rheumatology. We thought it is something rheumatoid arthritis, but we saw the spine like this. We saw the spine like this, see the pigmentation and all this, and urine was like this. So what was the diagnosis? Anybody, any guess? This was onchronosis. So crystals you can be seen. This is our own, we did a lot of synovial biopsies we did, and we proved that every arthritis is not rheumatoid arthritis, like this synovial where the gout crystals are sitting. This is my own pic. I took it long back. This is gout crystals in synovium by arthroscope. This is a histoplasmosis, the only fungal infection slide in this country, with patient had come with a joint pain and a testicular mass, and testicular mass biopsy was normal because they didn't look for fungus, but he had arthritis. So I took a biopsy and I said, please rule out fungus also. So this was a fungus, histoplasmosis, synovial chondromatosis, pigmented villoneuro-synovitis, amyloidosis, all synovium slides, onchronosis, synovial sarcoma, hemochromatosis, leprosy. So last slide, take home message, autoimmune diseases are common. They are not uncommon. If but you should not diagnose every joint disease as rheumatoid. They can be something else. That's why I told you it can be a osteoarthritis. It can be something else. So as a comprehensive workout, if some patient come for arthritis, it can be autoimmune, it can be not. Both should be learned. But autoimmune disease is also common and dreadful. The autoimmune diseases can affect other organs also, liver, kidney, but joint disease are well researched. That's why it goes to rheumatologist. Beside joints, other system also gets affected, like kidney and liver. They are multi-system disorders. So rheumatoid arthritis is not a disease of joints. Other systems like eyes, kidney, others are involved. So they are systemic autoimmune diseases. And at your must remember, there are two hallmarks of this disease is rest stiffness. So you must not forget to ask, अरे यार तुम्हारा रात में अकड़ जाता है क्या सुबह सुबह? हाँ डॉक्टर साहब रात में अकड़ जाता है. Rest stiffness is the hallmark of autoimmune inflammation. And if so many other systems are involved, multi-system diseases. डॉक्टर साहब मेरे जोड़ में भी दर्द है, मेरी आंख भी सूख रही है, मेरे बाल भी झड़ रहे हैं, मेरे मुंह में छाले हैं, मेरे को pleural effusion हो गया. They are the hallmark of autoimmune inflammation, systemic multi-system diseases. Thank you so much. Thanks.
Thank you so much, sir, for the wonderful presentation on Autoimmune Arthritis Day. I would like to request all the participating doctors, those who have joined in this session, kindly forward your questions so that sir can answer all your queries. And again, I would like to thank all of you for joining today's session. So we already received our first question. First question is, what is juvenile idiopathic arthritis and is it genetically similar to the rheumatoid arthritis?
Any arthritis in children, if you exclude many other, like you exclude infection, you exclude the, so it's a diagnosis of exclusion. So you must exclude the other known causes of arthritis. What are the known causes of arthritis? Like infection, you must exclude the malignancy, ALL, AML. If you exclude all these diseases, then we call it juvenile idiopathic arthritis, all called JIA. They are different diseases than rheumatoid arthritis. They have a different codes. We call it polyarticular, we call it systemic onset. That's a disease by itself, the subject by itself, but they are different diseases than rheumatoid arthritis, though the polyarticular disease behaves like rheumatoid arthritis.
Thank you so much, sir. Next question we received. What causes the tissue destruction in rheumatoid arthritis?
Yeah, so tissue destruction is like synovium. The synovium pannus, the vascularity. Synovium grows like it's like a slow growing cancer. In fact, it was earlier called as slow growing B-cell lymphoma. So the synovium gets inflamed, and that inflammation that drills into the bone and they causes the destruction. So the pannus formation causes destruction, and more research has been done. It is the cytokines, TNF, and other cytokines, IL-1, IL-6, they all causes destruction. So that is how the story of rheumatoid arthritis is there.
Thank you so much, sir. Again, I would like to request all the doctors, if you have any questions left with you, please put forward to it so that I can share with sir. I know it's already over the time.
I think people have understood it.
Yes, sir. So we received another question. Right. Other than medication and surgery, which therapies exist for rheumatoid arthritis?
Well, for any disease, a good healthy life there definitely helps. But the diet alone, we always advise people not to smoke, because smoking and arthritis has a very huge link. A good lifestyle. If you're sleeping every day 2 o'clock, you're not getting adequate sleep, so that you have a lot of changes in the blood. So that causes any disease can be aggravated. So any disease, not only rheumatoid arthritis. So most of the disease have the similar principle, that you must have adequate sleep, you must have a good diet, and you should not smoke. that will help, and a good exercise and everything. But if somebody says exercise can only cure rheumatoid arthritis or diet, that is a misnomer. I don't think so.
Thank you so much, sir. We received another question. Question is, what are baseline variables associated with the development of psoriatic arthritis in multivariate analysis?
Look, the baseline variables, first thing is a psoriasis means somebody has to have a psoriatic arthritis means somebody has to have a history of psoriasis. If somebody doesn't have a history of psoriasis, we always ask, your family has a history of arthritis? So the one variable is either he has a skin disease or his mother, father has a skin disease. That is number one. Or somebody is a nail disease. That is number two. Somebody is arthritis, and this arthritis can be polyarticular like rheumatoid. It can be just backache. So his spine can be involved. It can be arthritis mutilans. Just all joints are involved. So that can be just oligoarticular. So these are the few variables for the psoriasis, for the whether nail disease, skin disease, arthritis, and arthritis of different types. So that is how we pick up the psoriasis and psoriatic arthritis. And of course, we always take a help of dermatologists to see whether it's a psoriasis or not, because psoriasis can be sometimes confusing. The classical psoriasis is a scaly lesion, or it can be it can be presented at classical sites, either in the extensor surface like elbow, or near the navel, or on the knees, or sometimes can be palmar plantar. But I can tell you, even the biggest of his dermatologists sometimes get confused about diagnosing a psoriatic lesion when it is atypical.
Thank you so much, sir. Sir, we will be taking one last question of this session. Actually, we are getting many of them. So, last question of today's session is, which factors are associated with more rapid progression of knee osteoarthritis?
Look, it's very, as on today, the knowledge is probably it is a more of a degenerative disorder. But more and more, you never know tomorrow what will happen. As on today, we know the first is the age. If I'm 80-year-old, I have a more osteoarthritis rather than I'm 50-year-old. Obesity, if I'm obese, if I'm a smoker, if I'm diabetic, if I have a thyroid, if I have a family history, if I'm a sedentary person. These are the few factors which increases the osteoarthritis prevalence, and of course the genetics. A lot of work is going on genetics of the osteoarthritis. So there are a few factors which can aggravate osteoarthritis. I think, thank you so much. I have to also leave somewhere. I have to go for a dinner somewhere. So my wife is also waiting down. I think I have done my duty. If somebody has a question to me, my phone number can be shared. They may not ring up, but if they ask me on WhatsApp, I am available, and I'm working in Gangaram Hospital. Anytime I can be of any help, I'll be there as a good teacher. Thank you so much.
Thank you so much, sir. Thank you for sharing the knowledge with us. So with this, we are wrapping this session here. And I would like to also thank all our participating doctors for joining today's session and make the session a great success. Thank you, everyone, and good night.
Good night. Good night.